Why the American model is built on teams, not just surgery. Do you believe bariatric surgery is simply a stomach operation? If that's what you think, you are seeing only the surface of a much deeper medical structure. In the United States, bariatric surgery is not treated as an isolated technical event. It is managed as part of a comprehensive, multidisciplinary obesity treatment system designed to improve long-term metabolic health, reduce surgical risk, and prevent relapse. The surgery may last 2 hours, but the preparation, stabilization, coordination, and follow-up can last a lifetime. And that difference changes everything. Obesity is not simply excess weight. It is a chronic, progressive, multifactorial disease influenced by complex biological and behavioral systems. It involves hormonal dysregulation of hunger and satiety, insulin resistance and glucose instability, chronic low-grade inflammation, sleep disturbances, psychological coping mechanisms, genetic predisposition, medication side effects, metabolic adaptation to dieting, environmental and lifestyle stressors. When someone says, "I'm having bariatric surgery," what they are actually entering is a structured medical transformation process. In accredited American bariatric centers, surgery is only one component of a coordinated care model. This model is built around the understanding that long-term weight loss success depends not just on anatomy, but on metabolic stability, psychological readiness, nutritional adequacy, and cardiovascular safety. Early bariatric programs decades ago focused heavily on surgical technique. Surgeons improved stapling devices, refined anastomosis methods, reduced operative time, and minimized bleeding risk. But something became clear over time. Technical success did not always equal long-term success. Some patients regained weight. Some developed severe vitamin deficiencies. Some experienced emotional crises. Some struggled with hypoglycemia. Some felt lost after the first post-operative year. The problem was not surgical precision. The problem was fragmentation of care. When patients were treated only as surgical cases and not as complex metabolic patients, gaps appeared. The American model evolved in response to those gaps. Today, multidisciplinary bariatric care is considered the standard of care in the United States. This means high-quality centers operate as integrated ecosystems, not as isolated providers. The bariatric surgeon does not function alone. The registered dietitian is not just an optional consultation. The psychologist is not simply an evaluator. The endocrinologist is not a backup specialist. They operate together as a coordinated unit. And here is the critical difference. In the US, the discussion is no longer, should we have a team? The discussion is, how do we optimize team integration to improve outcomes? Because data consistently shows that structured multidisciplinary programs achieve lower complication rates, higher long-term weight stability, better diabetes remission durability, reduced hospital readmissions, improved patient satisfaction, stronger adherence to lifestyle modification. Why? Because obesity is systemic. You cannot correct a systemic disease with a single intervention. You correct it with layered strategies. Think of bariatric surgery not as a single door, but as a gateway into a structured continuum of care. That continuum begins before the first incision and continues long after the operating room lights are turned off. Preoperative assessment identifies hidden risks. Psychological screening stabilizes expectations. Metabolic evaluation reduces anesthesia danger. Nutritional correction prevents post-operative deficiency. Cardiopulmonary clearance minimizes intraoperative risk. Structured follow-up prevents relapse. This is architecture, and architecture requires engineering. If you are considering gastric sleeve, gastric bypass, or any metabolic procedure, the most important question is not simply which surgery you will have. The most important question is, What system of care will surround you? Because surgery changes anatomy, but coordinated care changes trajectory. In the next section, we will break down exactly how each specialist within a multidisciplinary bariatric surgery team contributes to safety, surgical selection, metabolic regulation, and long-term weight loss success. And once you understand how this integration works, you will never again see bariatric surgery as just a stomach operation. The core team. How integrated decision-making protects the patient. Now that we understand why the American model is built on coordinated care, let's break down how the multidisciplinary bariatric team actually functions in real clinical practice. We begin with the bariatric surgeon. The surgeon leads the operative strategy, but in high-level American centers, surgical planning is never isolated. The choice between gastric sleeve, gastric bypass, duodenal switch, or revisional surgery is influenced by structured multidisciplinary input. For example, imagine a patient with obesity and severe gastroesophageal reflux disease. If the gastroenterologist identifies advanced esophagitis or Barrett's esophagus during preoperative endoscopy, the team may strongly favor gastric bypass over sleeve to reduce long-term reflux risk. Now imagine a patient with long-standing insulin-dependent type 2 diabetes. In that case, the endocrinologist's assessment of beta cell function and insulin resistance may influence the selection of a procedure with stronger metabolic impact, such as bypass rather than sleeve. If imaging shows significant liver enlargement due to fatty liver disease, the surgeon may require a structured preoperative weight reduction plan supervised by the dietitian to reduce liver volume and improve operative safety. In other words, surgical choice is not based on preference. It is based on layered evaluation. The surgeon synthesizes findings from every specialty. Now let's examine the registered dietitian, often the central figure in long-term bariatric success. In American bariatric programs, the dietitian is not simply providing meal plans. They are responsible for metabolic preparation and lifelong nutritional safety. Before surgery, the dietitian evaluates baseline protein intake, meal timing patterns, emotional eating triggers, iron stores and ferritin levels, vitamin B12 and folate, vitamin D and calcium, fat-soluble vitamins, hydration habits, previous dieting history. Many patients enter surgery with undiagnosed micronutrient deficiencies. If iron deficiency, anemia, vitamin D depletion, or protein inadequacy are not corrected before surgery, post-operative complications become more likely. After surgery, nutrition becomes even more structured. Patients transition through clearly defined phases. Clear liquids to protect surgical healing. Full liquids to maintain hydration and protein intake. Purid foods to reintroduce texture safely. Soft solids to adapt digestion. Long-term structured intake focused on protein prioritization and micronutrient supplementation. The dietitian monitors for dumping syndrome, reactive hypoglycemia, protein malnutrition, hair thinning from rapid weight loss, bone density risk, long-term vitamin deficiency. Without this oversight, patients may technically lose weight, but compromise health. Now consider the psychological specialist. In the United States, behavioral health evaluation is considered essential to bariatric surgery readiness. This assessment is not about approval or rejection. It is about identifying psychological risk factors that could interfere with long-term success. These include binge eating disorder, emotional eating patterns, trauma history, depression or anxiety disorders, substance use vulnerability, unrealistic expectations about surgery. Surgery changes anatomy. It does not automatically change coping mechanisms. If food has historically functioned as emotional regulation, stress relief, or trauma buffering, those patterns must be addressed before surgery. Patients who receive structured psychological support before and after surgery demonstrate higher adherence rates and lower relapse into maladaptive behaviors. Next, the obesity medicine specialist or endocrinologist. Obesity is deeply connected to metabolic regulation. The endocrinologist evaluates thyroid dysfunction, insulin resistance, cortisol abnormalities, polycystic ovary syndrome, metabolic syndrome markers, advanced diabetes management. Medication regimens may need adjustment before surgery. After surgery, rapid metabolic shifts require careful monitoring to prevent hypoglycemia, overtreatment of diabetes, or thyroid imbalance. The endocrinologist ensures that metabolic adaptation supports weight loss rather than destabilizes it. What makes this team powerful is not the presence of multiple specialists, it is their integration. Cases are often discussed in structured meetings. Findings are shared. Conflicts are resolved collaboratively. Surgical planning adapts to metabolic reality. This is precision medicine applied to bariatric surgery, and this integration dramatically reduces preventable complications. In the next section, we will explore how cardiology, pulmonology, gastroenterology, radiology, exercise physiology, and long-term follow-up systems create additional layers of protection that extend far beyond the operating room. Because true bariatric success is built not only on intervention, but on sustained monitoring. Risk reduction, organ safety, and the continuum of care. Now that we've explored the core specialists directly involved in surgical planning and metabolic preparation, we need to go deeper into the safety architecture that surrounds bariatric surgery in the American model. Because weight loss surgery is not only about reducing stomach size, it is about protecting every major organ system during a period of rapid physiological change. Let's begin with cardiology. Patients seeking bariatric surgery frequently present with hypertension, dyslipidemia, insulin resistance, or long-standing obesity-related cardiac strain. Even in younger patients, undiagnosed cardiovascular risk can exist. The cardiologist evaluates electrocardiogram findings, echocardiogram results, exercise tolerance, structural abnormalities, coronary risk factors, arrhythmias, heart failure risk. In some cases, additional testing such as stress testing or coronary calcium scoring may be required to assess subclinical coronary artery disease. Why is this critical? Because anesthesia places stress on the cardiovascular system. Rapid fluid shifts, airway management, and metabolic changes during surgery demand cardiac stability. Preoperative optimization of blood pressure, heart rate control, and medication management reduces intraoperative and post-operative risk. Now consider pulmonology. Obstructive sleep apnea is highly prevalent in patients with obesity, yet many remain undiagnosed. Sleep apnea increases the risk of perioperative hypoxia, cardiac arrhythmias, and complications during recovery. The pulmonologist evaluates pulmonary function tests, airway resistance, oxygen exchange capacity, sleep studies when indicated. If sleep apnea is diagnosed, CPAP therapy may be initiated before surgery. This reduces respiratory complications during anesthesia and improves oxygen stability in the recovery phase. Respiratory optimization is not optional. It is protective. Next, gastroenterology. Upper endoscopy is commonly performed in American bariatric programs prior to surgery. This allows identification of gastritis, hiatal hernia, esophagitis, Barrett's esophagus, H. pylori infection, mucosal abnormalities. These findings significantly influence surgical selection. For example, severe reflux or esophageal inflammation may favor gastric bypass over sleeve gastrectomy. Without endoscopic evaluation, procedure selection may ignore critical risk factors. Radiology also plays a central role. Preoperative imaging may identify fatty liver enlargement, abdominal wall hernias, adhesions from prior surgeries, anatomical variations. A significantly enlarged fatty liver can increase surgical difficulty and bleeding risk. In such cases, a supervised preoperative diet may be implemented to reduce liver size before surgery proceeds. This is risk engineering. Now let's move beyond immediate surgical safety and into the concept that defines American bariatric care: the continuum of care. The continuum does not end at discharge. It extends into structured long-term follow-up. Why? Because the body adapts. After bariatric surgery, hormonal patterns shift dramatically. Ghrelin levels change. Insulin sensitivity improves. Glucose metabolism recalibrates. Energy expenditure adjusts. Without monitoring, patients can experience reactive hypoglycemia, nutritional deficiencies, muscle mass loss, bone density reduction, weight plateau, or regain, psychological destabilization. Structured follow-up includes routine laboratory panels, micronutrient monitoring, metabolic marker tracking, psychological reassessment, exercise progression planning. The exercise physiologist plays an essential role here. Rapid weight loss without resistance training can result in disproportionate lean muscle loss. Loss of muscle reduces resting metabolic rate, making long-term maintenance more difficult. Structured strength training preserves metabolic integrity. And finally, the case manager. Often underestimated, the case manager ensures communication between departments, coordinates appointments, manages insurance documentation, and prevents fragmentation of care. Fragmented care increases risk. Integrated care prevents oversight. Multidisciplinary bariatric surgery is not complexity for its own sake. It is layered protection. It is structured oversight. It is systemic stability during systemic change. In the final section, we will examine real-world scenarios that demonstrate why this integrated American model consistently produces better long-term outcomes and what happens when the team approach is missing. Because understanding the model is one thing, seeing its impact in action is another. Real-world outcomes, system integration, and why this model consistently wins. Now that we've explored the structure of the multidisciplinary bariatric surgery team and the continuum of care that surrounds the procedure, let's examine what this looks like in real-world clinical outcomes. Because theory matters, but outcomes matter more. Let's start with a practical scenario. A patient presents with obesity and chronic acid reflux. Without proper gastroenterology evaluation, a gastric sleeve might be selected based solely on weight loss goals. But with preoperative endoscopy, the team identifies significant esophagitis and early Barrett's changes. During multidisciplinary case review, the surgeon, gastroenterologist, and dietitian discuss the long-term implications. The surgical plan shifts to gastric bypass. Post-operatively, reflux improves dramatically. The patient not only loses weight, but experiences improved quality of life. That is team-based precision in action. Now consider another case. A patient is highly motivated for surgery, but has a history of untreated depression and emotional eating patterns triggered by stress. Without psychological evaluation, surgery might proceed. But within months, the patient could struggle with emotional dysregulation, maladaptive coping behaviors, or even transfer of addiction from food to alcohol. In the American model, behavioral health screening identifies vulnerability before surgery. Therapeutic support begins early. Coping strategies are built. Expectations are recalibrated. Surgery proceeds only when psychological stability is established. Long-term adherence improves. Relapse risk decreases. Now consider metabolic instability. A patient presents with poorly controlled type 2 diabetes and hypertension. Instead of rushing to surgery, the endocrinologist adjusts medications. Blood sugar improves. Cardiology evaluates cardiac function. Pulmonology confirms airway safety. The surgical window is optimized. The procedure is performed under stabilized metabolic conditions. Post-operatively, diabetes remission occurs. Cardiovascular risk decreases. The outcome is not accidental. It is engineered. This is the American model at its core, engineered success through integrated oversight. But what happens when the multidisciplinary system is absent? When surgery is performed without full metabolic stabilization? When micronutrient deficiencies are not identified? When psychological readiness is not assessed? When follow-up is inconsistent? The risks increase. Higher complication rates, nutritional collapse, severe hypoglycemia, weight regain, depression, loss of lean muscle mass, reduced long-term satisfaction. Bariatric surgery is one of the most powerful metabolic interventions available in modern medicine. But power without structure can become unstable. The multidisciplinary bariatric team acts as a stabilizing framework. It transforms a procedure into a coordinated therapeutic journey. It converts weight loss into metabolic improvement. It transforms anatomical change into sustainable health outcomes. And perhaps most importantly, it provides accountability. Regular follow-up visits reinforce behavior change. Laboratory monitoring prevents silent deficiencies. Psychological reassessment prevents relapse. Exercise planning preserves metabolic rate. Nutritional supervision protects organ systems. In the United States, accredited bariatric centers conduct structured case reviews. Specialists discuss patient progress. Treatment plans evolve as physiology evolves. The patient is never treated as a static case. They are treated as a dynamic system. Because human biology is dynamic, hormones shift, metabolism adapts, behavior evolves, stress changes, life circumstances shift. And without structured multidisciplinary support, these variables can destabilize progress. When patients ask, "Is bariatric surgery safe?" the most accurate answer is, it is safest when performed within an integrated system of care, not simply in an operating room, not simply by a skilled surgeon, but within a coordinated network of expertise. If you are considering gastric sleeve, gastric bypass, or revisional bariatric surgery, evaluate not only the procedure offered, but the structure behind it. Ask, is there a registered dietitian involved long-term? Is psychological support available beyond clearance? Is metabolic monitoring structured? Is cardiology or pulmonology consulted when necessary? Is follow-up lifelong because surgery changes anatomy? The multidisciplinary team changes trajectory. In the American model, bariatric surgery is not a single event. It is a medically supervised transformation process. And when that process is built on integrated collaboration, the results are not only measurable in pounds lost. They are measurable in improved diabetes control, stabilized blood pressure, preserved bone density, restored mobility, psychological resilience, and enhanced quality of life. That is the real architecture of successful bariatric medicine, not just surgical precision, but coordinated care. And when you understand that difference, you understand why the American multidisciplinary model continues to set the global benchmark for bariatric surgery success.